Good afternoon. I'm Hyo-Sookim, SNU Hospital. Welcome to fourth live cases. My collaborator is Dr. Yang Han-mo, and second operator is Kim Ji-hoon. Jae-kyun should attend this room, but I just left the CTO case from the other room and leave the Jae-kyun. I request Dr. Asakura to continue the CTO intervention, and we reached the reverse card technique and externalization of retrograde wire. At the end of session, we can report the final results of third live case of CTO.
Okay.
Okay, slide please.
Go ahead.
Plus. This patient is 79 years old male. Chief complaint is progressive dyspnea on exertion, functional class 3, since 9 months ago. He has various kinds of comorbidity. First, he underwent cabbage 6 years ago, and emphysema, prostate cancer, gastrectomy, and CNS vasculitis under the prescription of steroid. Plus, chest X-ray suggests emphysema, plus chest CT confirmed it, and PFT show moderate degree restrictive pattern. Plus, ECG showed LVH in strain without any conduction disturbance. Plus, brain MRI showed multifocal punctate enhancing lesions, which is improved by steroid therapy. Plus, even though he has a multiple comorbidity, SAT score is just 5%. Still, intermediate risk patient. Plus, echo finding shows normal dimension, normal function, but inferior scar. That may be associated with cabbage. Severe AS with moderate AR. Plus, severe stenosis is well demonstrated by pressure gradient. Mean gradient more than 60, peak gradient more than 100 total. Area is less than 0.7 square centimeters. Plus, annulus 20 millimeter, sinus valsalva about 30 plus. T shows the same finding with more severe AL on the top of severe AS. Thus, severe ASR. Plus, coronary angiogram shows total occlusion of LAD, plus, which is well revascularized by Lima graft, supplying LAD and circ of this marginal branch. I say it's okay. Thus, coronary artery is okay for this patient. Plus, root arterography shows moderate degree AR with calcified leaflet and aortic stenosis. Best angle is just caudal 5 degree. Plus, iliofemoral artery is good, but there is a huge eccentric calcification in right common iliac artery. Plus, measurement is good. Plus, general aorta iliofemoral artery looks good, except for focal calcified lesion at proximal common iliac artery, right side. Plus, in other part, it's okay on the right side, plus on the left side. Plus, aortic arch looks good. Plus, tricuspid aortic valve with mild degree calcification was noticed in annular plane. Plus, it's a little bit moderate degree, but there is no LVOT calcification. It's a good sign. Plus, prediction of leakage can be assessed by AV calcification. Two factors, total burden and eccentricity. Total burden is 437 cubic millimeter in this case. Eccentricity by leaflet-based method, 116. By partition method, 110. All the values are below cutoff value, suggesting low risk of post-TAVI leakage. Plus, The measurement is shown here. Annulus about 21, height of coronary ostium 14 and 11. Annulus area is 337 square millimeters in our hospital and 355 in Edward Life Science. That corresponds to SAPIEN3 valve 23 with the oversize index about 14%. Plus, I suggest there are a discussion point regarding the oversizing of the valve. This slide shows a tight association of oversizing and paravalvular leakage of the TAVI. When you perform TAVI with oversizing above 10%, there's a less chance of moderate degree AR. But if you perform TAVI with just 5% oversizing, there is a greater instance of moderate severe AR. If you undersizing on the left side, there is a chance of severe, moderate severe paravalvular leakage. Thus, recommended oversize index is about up to 20%. My personal preference is about 10% or 5 to 10%. Plus, if you're talking about oversizing index, you have to make sure. There are two different methods calculating oversize index. The first one is area-based calculation. The other one is diameter-based calculation. On the left side, if your patients, it's the same patients. But when you calculate oversizing by area, it may be 20%. The same patient, if you calculate oversizing by diameter, it is 10%. Thus, we have to be very cautious regarding the communication of oversize index. Please make sure the method used for that calculation of oversizing. Plus, for these patients, area is about 355 square millimeters, and 23 millimeter SAPIEN3 valve area is 409 square millimeters. So divided, the results 114%, leading to oversize index by 14%. I think it is an acceptable range of oversizing. Then let me show you the angiogram taken just a few minutes ago. Angio, please. Angio. I usually puncture the common femoral artery under guidance of fluoroscopy. Plus, then we checked once again the root arterography at caudal 5 degree, the best angle to delineate the three cusps in a single plane. We can see calcification of aortic valve annulus and moderate degree AR. Plus, then advanced the sheath. We have to be cautious regarding the movement of calcific nodule on the wall of iliac artery, as shown here. We can see many calcium nodules around in external and common iliac artery. Plus, then I put the straight wire into the left ventricle under the guidance M+ diagnostic catheter. Plus, then advance M+ catheter into LV. Plus, exchange to shaped wire. Plus, introduce catheter pigtail. Pigtail catheter is introduced and perform a double tracing. Can you see the pressure profile of LV and aorta? Pressure
Yes.
profile, okay. We can see the peak pressure of LV is 200, aorta is 140. There is a wide pulse pressure of aorta, suggesting moderate degree AR. The AR index is just 13. It's moderate to severe AR. This is the point that we have progressed today. From now on, I'd like to show you the actual performance of TAVI of SAPIEN3.
Okay, before your
If there is
procedure,
any
we
comment,
have
question, please,
some.
while I do my job. There's already a moderate to severe AR, thus I don't like to do pre-dilatation. Just I do skip the PDL.
Okay.
Pure AR without stenotic component or calcification, that is contraindication of TAVI. We just believe in the stenotic component or calcification that may fix the valve system, prevent embolization of valve. Okay?
Okay, go ahead.
Okay, there are three markers. That is a useful marker in the later phase to withdraw the catheter before inflation of the valve. The upper side, there is a space, the three markers. Center is center marker. Both ends is a valve marker. Thus, I move the valve to the three upper marker segment. First, I move the pusher catheter, then adjust further the valve by rotating the knob to localize the valve between the two end marks. Okay. Then I advance whole system through the aortic arch. Okay.
Yeah.
Wire stay.
Yes.
Then at this point, I flexed the tip. Left trapezius. In the LAO view, we can see more easily the scratch of the outward during advancing the system. Wire stay.
Stay.
Okay, valve, which location is good. Then I remove the pusher back. Up to center marker of triple. There is movement of catheter, then lock. Once again, check the dye.
Test.
It's okay. No. Test again.
Test.
Okay. Just 다이를 좀 많이 주고.
타입 좀 많이 써.
자, pacing test. Pacing on. Okay, pacing off. Okay, we are going to inflate the valve system. Pacing on. Dye test. Inflate.
Inflation.
Slowly,
Slowly.
slowly,
Slowly.
slowly, full,
Full.
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 1,000, 2,000, 3,000, 4,000, 5,000. Deflation.
Deflation.
Pacing off. 오케이, 저장. T.
Excellent.
메인 하면 해줘야지.
나가고 있습니다.
Transfer section. 메인 화면으로 오케이. How about the results?
Okay, excellent.
No regurgitation. No trivial at 12 o'clock. That may be a coronary flow. Okay, just withdraw. 풀고. 자, wire stay.
예, 스테이 하겠습니다.
좀 밀어내야 돼.
예.
stay.
네, 스테이 하겠습니다.
꺼낼까?
네,
그래서 거기
끊겠습니다.
볼 필요 없고.
네,
저
끊겠습니다.
Y를 봐야 돼.
네, 끊겠습니다.
Okay. Please enjoy TE while we retrieve the system. Just let me check the orthography after inserting
T 빼주세요.
by inserting the pigtail.
다이 채워져 있죠? 네, 다이 잘 쓰고.
Pigtail. I'd like to exchange the stiff wire to pigtail because there is really no regurgitation. Thus, there is a low possibility of joint ballooning. Thus, first, I exchanged the stiff wire in LV to safer pigtail, then assessed root arterography. As a second live demonstration today, we can see the stiff wire bias may inhibit the accurate assessment of air regurgitation. Thus, it's better to remove the stiff wire outside LV. We are now equalized both pressure for double tracing of LV and aorta. Pressure profile. There is no pressure in between two chambers, but there is still very wide pulse pressure of aorta, suggesting regurgitation or something else. Then we are going to check the root arterography with the left ventricular catheter on site. In T, there is no significant regurgitation,
오케이, 스탑.
but AR index a little bit. How much AR index? AR is just 20. So interesting finding. It is very important to see the valve en face or tangential view. 신의 준비. Shoot. No regurgitation. So I remove the catheter. Even though there is no regurgitation, the air index is just 20. Because of why? Stiff peripheral vasculature. The SAPIEN valve has its own outside skirt that expands for about 10 minutes. So to assess exactly the leakage, we have to wait for 5 or 10 minutes. Cross-section view. So continuous flow at the 12 o'clock seems a coronary flow. No regurgitation outside valve.
Excellent lesion.
Caudal.
엔지오. 엔지오. T 빼주세요.
Even though the time is not past enough, let's check the arterography once again. 자, 신의 준비. Shoot. No regurgitation. 자, 아래로 caudal. The depth is very ideal. There is no conduction disturbance. Okay, once again, Sine.
트리비얼.
Okay. Elaeocranial. In the year of XT, it is inevitable to see there a certain amount of leakage, but in the new year of SAPIEN3, it's really satisfactory. It's really perfect.
Faint amount
Once
of
again.
the regurgitation.
네.
Very faint.
Just 30 seconds. just pass the whole system into the left ventricle and retrieve the pusher catheter. Just adjust, test, rapid pacing, inflation, deflation, off. Just 1 minute. Thus, I really enjoy SAPIEN3 in case of urgent case or patients with very hemodynamically unstable status. Now the pulse pressure looks fine, but if you repeat the calculation, the AR index may be increased. This core valve is really bad version. In two important aspects. The first one is there is no mechanism to prevent leakage. So there are a lot of leakage when we use core valve and several years ago. The second point is implantation depth is very difficult because recapturability is very difficult. Thus, there is a high instance of complete AV block or pacemaker implantation rate, and large instance of moderate degree paravalve leakage. But Evolut-R significantly improved. But there's still no outside fabric. Thus, in terms of prevention of leakage, Evolut-R is not so different from core valve, but the important evolution is easily recapturable. Thus, it is easier to optimally deploy the Evolut-R. That may prevent pacemaker implantation. Thus, at this point, compared to Evolut-R and SAPIEN3, the only difference is prevention of leakage. It's superior with SAPIEN3. But in contrast, in the other aspect, Evolut-R is very shallow and flexible. It's very safe device. No risk of aortic tear, less risk of coronary obstruction. That is a strong point of Evolut-R compared to SAPIEN3. Thus, we have to use each system depending on the feature of each patient. If you use the largest valve, it increases up to 16 French, but we use the smallest valve,
Yeah, 223.
it's probably 14 French. But outside, diameter is 18 French.
Yeah. Do you have
And
any
if the valve pass, the difference is it's very tricky. Some company mentioned the profile as the internal diameter. Usually 8 French sheath means internal diameter is 8 French. 14 French, now I use today, is the internal diameter is 14 French. Actual external diameter is plus 4 French. 14 increases 18 French. But inline sheath 14 French means out diameter. Real 14 French. Okay, there is a huge amount of blush in the PL territory. Okay, retrieve the left guide wire and Corsair, then check the left system,
Aurocranial.
aurocranial with flushing, sufficient flushing. Okay. Engaged.
Good.
It's good. PL branch is bigger than we expected.
Aureo and left side.
So we are going to check the left coronary artery. It's engaged. No.
Ah,
Okay.
okay, I see.
No. It is important to make sure the safety of left coronary artery that is used as a feeding vessel or collateral navigation. But even though septal collateral channel is very prominent, it's not always the answer. In this case, it's very
Yeah.
important lesson.
Diagnostic yasta.
Even the septal collateral channel is very prominent, the final location is not good. So I select septal 1 channel that reach into the PL branch, but the angulation is not good. Thus gave up and changed another epicardial collateral channel from circumflex. He changed to diagnostic left coronary artery catheter and make sure there's nothing in left coronary artery. It took 90 minutes to find the pass vitro wire into the true PL branch, and another 90 minutes to pass ante wire into the PL branch. Okay, looks good. But aortic cauda? To see the epicardial collateral channels more. Okay. So there's no damage of epicardial collateral channels connecting circ and PL branch. That is used as our retro wire navigation.
Okay, this is the final shot.
Final shoot. Okay.
Okay, thank you.
Okay. Thank you, Dr. Asakura.
Thank you very much,
over
Dr.
and
Kim.
make the case completely,
Thank you
perfectly.
very much.
Yes, congratulations for very excellent
Okay.
cases. Yeah, perfect.